Earlier today, the National Coalition on Healthcare held a discussion on the Physician Payment Sunshine Act. We hear from two physicians who discuss the challenges and benefits this section of the healthcare law currently provides. This is an hour and a half.
On healthcare, our mission is healthcare affordability, and one of the key strategies to achieve that is greater transparency. Today, we have a chance to look at the Physician Payment Sunshine Act and see how it's doing. This is one of a series of events that the National Coalition sponsors to lift up what we see as promising developments in healthcare. Today is one of several congressional briefings, and so I welcome you today. Thank you for coming. Thank you especially to C-SPAN for being here with us. And those of you watching on TV, I think you'll find this interesting state of play for the Physician Sunshine Act. To introduce our panelists, I'm going to turn to my friend and colleague, Deborah Whitman. Deborah is the Director of Policy at AARP, and she's been heavily involved in this issue. Deborah, it's all yours.
Good morning, and thanks, John, and thanks to the National Coalition on Healthcare. I think this is a really important issue that a lot of people don't know about. Section 6002 of the Affordable Care Act was previously known as the Physician Payment Sunshine Act, and it was a bipartisan piece of legislation introduced in the Senate by Senator Chuck Grassley, Republican from Iowa, and Senators Herb Kohl, a Democrat from Wisconsin. It also had House sponsors with Peter DeFazio and Henry Waxman. And the bill sought to lift the veil on the relationship between industry and physicians. It was a true piece of bipartisan legislation that was founded on a lot of the research that you're going to hear from some of our great speakers today. It was written in conjunction with the information that we got from the research community and the consumer community, represented by Pew and Allen here today, and AARP and AMSA and many other groups that were concerned that these relationships, the financial relationships, were impacting both the quality of health care and the costs of health care. And I have to say that the process was long and tireless. At the time, I worked for Senator Herb Kohl, and we had, with my colleague Chris Armstrong from Senator Grassley's office, about 300 meetings with consumer groups and industry groups to understand comprehensively what these relationships were, legitimate concerns from industry about context, about how we present the information to consumers, and how usable it is. And I'm very proud of this legislation because I think it will go a long way into helping lift this veil of uncertainty. Now, also as background, many states had started passing laws in this area. So we learned from state laws in Minnesota, in Vermont, in other states, a lot of information about what these relationships were. But because there were different reporting requirements in each state, there was a lot of chaos for the industry to actually make sure that they could report to those individual states. And so there was kind of a pressure to have a federal law where things were more cohesive and reporting requirements were more standardized. Now, this law, as I said, came from state legislation, went to federal legislation, and actually has spurned laws across the globe, although they are not all implemented the same. The French decided that it's great to report the financial relationships, but we shouldn't make the money about public. So the actual usefulness of some of the global laws are probably even going to be less than the United States laws. We also saw in the fall that there were a lot of bumpy implementation issues. Implementation had been delayed by delays in regulations getting out. Websites had issues. We've heard that before. There were issues in actually downloading the data and using it in a usable form. And there were concerns about whether data was both accurate and also given the proper context. So these are the issues that we'll be talking about today. And I'm really delighted because we have an amazing panel of speakers. First, we have Rodney Whitlock, who is just a real expert here on the Hill. He has 21 years of experience and is currently working for Senator Chuck Grassley as the Health Policy Director on the Senate Finance Committee. And he's previously worked on a variety of staff, including Representative Charlie Norwood. And he also is a part-time teacher at George Washington University for health policy. So we welcome Rodney. Second, we will have Adrienne Few-Berman, who's associate professor in the Department of Family Medicine at Georgetown University Medical Center. She's the director of Farmed Out, which promotes rational prescribing, and is the lead author of several articles on physician-industry relationship. Next, we'll have Alan Kokel, who's a clinical pharmacist and is Pew Charitable Trust Senior Director for Health Programs. Alan was very involved at both the state level and at the federal level. I can tell you I had him on speed dial for this legislation, and Pew continues to be very involved in the implementation of the legislation. And finally, we will have Dr. William Jordan, who's President-elect of the National Physicians Alliance, and he's also co-director of the Medical Student Education in the Department of Family and Social Medicine and Director of Preventative Medicine Residency at Milleflore Einstein. So we have a great panel. We'll let them each speak individually, and then we'll take questions at the end. Rodney?
So thank you all for having us today. I'd like to thank the National Coalition on Healthcare and John Rother for organizing this today. Thank you, C-SPAN, for being here as well and giving my wife an excuse to address me this morning. Senator Grassley has a long history in the subject of transparency in the public interest. He's worked in the subject of whistleblowers and whistleblowers' role in their ability to provide information for the judicial process, Medicare transparency of data, working with Senator Wyden and seeing that Medicare data could be released publicly for research purposes, and some of the work we've done in not-for-profit hospitals and providing information as to what they're doing with regard to providing services for the uninsured and the things that allow them to derive their not-for-profit status, the public benefit they provide. Senator Grassley continues to believe that more information available to the public is in the public interest, and that motivates how we approach, how we come to this subject. If you look at it, there's a significant amount of public disclosure also out there for participants. Clearly, members of Congress and staffers like me are subject to financial disclosure. The Freedom of Information Act makes information available to individuals about what their government is doing. And tax-exempt organizations have to provide certain information for their status. So the idea of providing information into the public forum is something that we have consistently supported and bring to this conversation. About a decade ago, we started looking at this, and it begins with investigations about what are the relationships between manufacturers of drugs and devices and biologics and providers. You have an early New York Times piece on a provider who is participating in a study on Seroquel and making recommendations for antipsychotics for teenagers. And what are the financial relationships that individual provider has? Turned out the provider was receiving money from 5 different manufacturers of similar drugs, not disclosed as part of the research. We went and did further research. We did investigations. There were media work where places like Baylor and Stanford and Harvard, where you have research going on and financial relationships that are not disclosed with the subject matter that is under research. And so we know that there is a there. We know there's something going on. The magnitude of it is unclear to us, but we know. We have work from groups like ProPublica and Pew out there showing that there is something worthy of legislation, of consideration here. Now, it's important to note that what we're talking about, when we talk about these financial transactions, money moving between the covered entities, the manufacturers, and providers, physicians, group purchasing, hospitals, these are not illegal. Make sure we're clear about that. These are not illegal. Kickbacks, those that fall under anti-kickback statutes, are, but that's not what we're talking about here. These are perfectly legal transactions, and the medical community argues rightly that they are legal, that we're not talking about things that should that are illegal or types of kickbacks. These are particularly related oftentimes to education, and that for doctors to take their time to be engaged in the educational process for themselves and for their peers is in the patient interest. And so these transactions are occurring around those types of things. And so if you look at how you approach this as a matter of legislation, now, some people could come to this with a very purist approach, an absolutist approach, that we should make these types of transactions illegal. That's not the way we approached it, working with Senator Cole's office of Wisconsin. We looked at it from more of a transparency perspective, that if these transactions remain legal, and we believe that they should, then they should be reported and made available to the public. Since they are legal transactions, after all, that there should be no qualms about making them publicly available, making them so that that they can be seen by the public and can be discussed. And so that was the genesis of the Physician Payment Sunshine Act, introduced, I believe, first in 2007, and ultimately becoming statute through the Affordable Care Act. Now, once in statute, it went through the implementation process. It was turned over to CMS to figure out how to make it work and bring it to the public. And CMS, I'll drop into my Southern colloquialism, bless their little hearts, they have trouble with websites. So the rollout didn't go as expected. And in their defense, that the data available to them to be able to confirm identities of the providers out there to make sure the data was right was horribly flawed. And so that led to a rollout that was bumpier than anticipated, and certainly than we would have preferred. But they did get out the door. It is live. You can go in and start searching. And to CMS's credit, Dr. Agrawal and his team, that they have made consistent improvements on what is out there. They're turning data from de-identified to identified, and their plans for moving forward. And so from my office's perspective, we are very pleased with what CMS has done. And this is important because moving forward in the future, this really needs to be commonplace. This needs to be something that is just part of the healthcare relationships out there, that we come to expect it, it's available, it's searchable, and it just is. That it's not controversial, that everyone is comfortable looking at that. Because that's ultimately what we believe, from our perspective, is in the public interest, this transparency of the relationship, so that we all know, and so that it can be simply part of a conversation between a patient and a provider. A patient should be perfectly comfortable as an educated consumer looking at this data and seeing what their provider is doing, and then asking their provider. And a provider should be absolutely comfortable saying why the data is in there, what it says. Now, we know as we look forward, again, that there are things that will need to be approved on the site, and that's going to be a collaborative process. And that collaboration involves CMS, it involves the reporting entities, the manufacturers, and it involves the providers. And everyone has to take the vested interest they have in looking at the data and making sure it's always accurate, and making sure it provides proper context, so that the consumer then really gets to know what's occurring, to make these conversations that occur between the provider and the patient more beneficial. But we continue to stand that this is a good thing, a positive thing, and it is in the public interest, and it is in the patient interest. Now, to the sort of elephant in the room, the data is now out there, and we went from having suspicion to having actual data. And the actual data, and this is as of the December 19 refresh in 2014, that the magnitude of what is going on out there, these financial transactions, okay, that the total value that CMS published as of December 19th in these transactions was $3.7 billion. The number of records, those individual transactions that are occurring, or over 4.4 million transactions recorded. And it involved individual records for 366,000 physicians. And so there's a lot going on out there. Now, what that means, what can be done with the data, the researches that you can go into and find out about what is going on, that then is turned over to the research community. And how that then informs public policy will depend upon the research done. But that then is, again, a subject for the folks doing research, which is my segue to my fellow panelists here. Again, ready to answer questions and appreciate you all being here today.
Good morning. Happy to be here today. Please, are my slides loaded? Physicians find it very difficult to speak without slides, and you'll notice both physicians on the panel have brought slides today. My disclosure is that I'm a paid expert witness at the request of plaintiffs in matters regarding pharmaceutical marketing practices. And as stated before, I direct Pharmed Out, which is a research and education project in the Department of Pharmacology and Physiology at Georgetown University Medical Center. So the Physician Payment Sunshine Act is definitely a success. It's been wonderful to have this information out here. It's been a real gold mine for reporters, for researchers, and also for consumers. And just the fact of its existence is really important. Physicians don't like its existence, or at least physicians who are being paid by pharmaceutical companies don't like its existence. Apparently it's quite popular among divorce lawyers, though. ProPublica, of course, had put together publicly available information before the database released by CMS, and they've continued to refine that database, which has been really great. And they've also created several tools, not only Dollars for Docs, but Prescriber Checkup, and they have a wonderful series of 32 articles analyzing the data from the new database. It's really great. So if you haven't seen that, please take a look at it. I want to make a plea to keep our state disclosure laws as well. DC, of course, isn't a state, but Dr. Susan Wood at George Washington University is leading an effort that I'm involved with as well to report. We have disclosure laws in DC, and we do an analysis of the disclosures from pharmaceutical companies of payments to all healthcare practitioners every year, and we also do a special report. And I can tell you that the PPSA only picks up about 20% of what's required to be reported to DC. So some states, or non-states, have reporting laws that are even more stringent than the PPSA, and I would make a plea for keeping them. In our latest report, we actually looked at organizations in DC. We're required by law we can't actually name those organizations, but they may be represented in this room. And we found that of the almost $20 million that was spent on DC-based organizations, about a third of these organizations failed to disclose their corporate donors on either their website or in available annual reports for the year 2012. Anyway, our report is available on the DC Department of Health website, but disclosure should not just be limited to physicians and to other healthcare providers, but should also extend to organizations. Also, of 7 physicians on our list who served in leadership positions in research advocacy or specialty organizations that received over $100,000, the individual physicians who are in leadership positions also received large gifts. So what happens after the PPSA? Well, some kinds of promotion will stay the same. Detailing or drug rep visits, samples, the sponsorship of continuing medical education and other meetings, the use of KOLs, or key opinion leaders, which I'll talk about a little bit more, and direct-to-consumer promotion, which includes direct-to-consumer advertising, but also includes other kind of promotion, and even targeting of individual patients. If you have an expensive disease, pharmaceutical companies may send a visiting nurse to your home, or provide someone to help you fill out insurance forms to convince your insurance company to pay for an expensive medication. So one of the things that has gone away since 2009 is promotional items, but we collect them at Farmed Out, so I just had to show you our collection. So some marketing tactics have changed, however. Some have become more subtle, and some of the targets have changed. That to some extent, physicians are less important in choosing medications than other people, than other entities. So more and more formularies, pharmacy benefit managers, payers are deciding what gets paid for or how much is spent on various medications. And pharmaceutical companies will always try to affect whoever is affecting market share. If that's the physician, it will be physicians. If it's the patient, it will be the patient. If it's a payer, it will be the payer. And payers, there's a lot of shift towards targeting payers, especially with cost effectiveness studies, for example, because if you're a company with a really expensive drug, you're going to need to try and convince a payer that even though this drug is terribly expensive, it will save hospitalizations or it will save you money down the line somehow. So there's a lot of cost effectiveness studies and other studies that are meant to persuade payers to cover a drug. Disease awareness programs are very important, and pharma's getting very involved in a very scary way in disease management, that pharmaceutical companies would like to help healthcare providers and systems manage their patients. You should be very afraid of this. And there's a lot of partnering with government agencies, with medical groups, with professional organizations and specialty groups, et cetera, and also with consumer advocacy groups, some of which have been invented or have been created by pharmaceutical companies, and others that have been co-opted by them. There are very few consumer advocacy groups that don't take money from pharma. There are fewer than 10 national groups in the United States that do not take money from pharmaceutical companies. For individual physicians, the shift has been away from cash and towards more services. We'll do a website for you. We'll provide web pads that your patients can fill out their information, their medical history on, so that somebody doesn't have to transcribe that. That information actually gets sent back to pharmaceutical companies. It's deconfidentialized first, but it's a way for them to collect all this information. In fact, all of your medical records are also sold to pharmaceutical companies. Your insurance company sells those records. It's anonymized, so it's anonymized patient-level data. But pharmaceutical companies know everything about your health history, your hospitalizations, last time you went to a doctor, your allergies, your medications, the zip code that you live in, your body mass index. As long as they don't know your name, they are allowed to have longitudinal information on every other aspect of your health history. Pharmaceutical companies also fund TVs in waiting rooms that have fake news stories on them, possibly pharma ads, but often the messages are incorporated into the fake news stories. And you can imagine what a great audience this is. People stuck in a waiting room with old magazines are really going to be drawn to a screen in the room. There are new targets for pharma marketing, and one that I think is really important to mention are non-physician practitioners. So advanced practice nurses, which includes nurse practitioners, nurse midwives, and nurse anesthetists, and physician assistants. So these are practitioners who have prescribing authority in all 50 states. And 1 out of 4 prescriptions in the United States is written by an advanced practice nurse or a PA, 1/4 of all prescriptions. And There is no requirement in the PPSA to report any payments to these practitioners. The DC law does require payments to these practitioners. The PPSA does not. A quarter of all prescriptions is a lot of prescriptions, and PAs are being targeted, and advanced practice nurses are being targeted. And another target that really flies under the radar is social workers. In many jurisdictions, especially busy city mental health clinics, it's the social workers who are making the diagnoses and choosing the drugs that their patients will be on. They're not signing the scripts, they're not signing the prescriptions because they're not allowed to. There's a healthcare provider signing them, but it's a social worker who's choosing what medication someone gets. This is an ad from industry. Are you sure you know who's writing your brands? Reach out to the prescribers who make your high decile targets, the NPs and PAs who write on their pads. So gatekeepers are really important. The receptionists, the nurses who work in a doctor's office, so even a nurse who is not a prescriber, a receptionist, a social worker who's not a prescriber, they can influence prescribing of a particular healthcare provider, and that's really important. So this is also from an industry magazine. This is also from an industry magazine. KOL, again, is a key opinion leader, and this just shows the matrix of everyone who has to be affected, all the people that the KOL can affect. This marketing is extremely elaborate and extremely subtle. So, like, let's say a physician doesn't see drug reps, which about 4 out of 10 physicians in the U.S. Now do not see drug reps. So pharmaceutical companies will actually figure out who their social contacts are in their professional networks. Who do they refer to? Who refers to them? Who do their kids play baseball with? Who's their spouse's best friend? And they will actually try and target those people in order to try and get a marketing message to the targeted physician. Marketing for a drug actually starts 7 to 10 years before a drug comes on the market. Now, it's illegal for a company to market a drug before it's on the market. So what they do is they market the disease. And that's done through key opinion leaders. And here's a company that specializes in building your brand before its birth, or what's called pre-launch marketing. So pre-launch marketing might highlight the severity of the disease that the new drug is meant to treat, or it might highlight the problems with existing drugs, or it might emphasize a particular mechanism of action, and then there's a drug on the market that magically has this mechanism of action. I think what we should really be watching for is the establishment or the redefinition of specific conditions. So pharmaceutical companies have actually invented some conditions wholesale, including hypoactive sexual desire disorder, daughter of the invented female sexual dysfunction, GERD, gastroesophageal reflux disorder. This is what used to be called heartburn, and we used to tell people to drink less coffee and drink less alcohol, smoke less, don't eat a full meal and go to bed right away, and now you've got to be on potent medications for the rest of your life. Pediatric bipolar disorder, what we used to call the terrible twos, excessive sleepiness, anyway. And there's been many other conditions that actually do exist, but have been redefined. So restless leg syndrome is actually a rare neurologic condition, but it's now been redefined to anybody who fidgets at night. I won't go over these others, but happy to discuss them with people. Oh, low T. Low T is a great one. So here's an award-winning ad campaign for a tragic medical condition, severe underarm sweating. So apparently injecting Botox in the underarm area can help with this, so now it's a serious condition. Low T. There are quizzes online on whether you have low T. We gave this quiz to everyone in my office, and everybody failed, including the 23-year-old women. Excessive sleepiness can be a real burden. Anyone suffer from that? So these are all conditions that have been invented by industry. Anyway, Farmed Out works with a lot of industry insiders, so we have information that that is unusual. These are some of our publications available on our website. We have promotional items available on the table outside. And we are planning our 5th conference. We've done 4 conferences on these topics. It will be June 11th and 12th, and I hope you all can come. It'll be at Georgetown. Thank you very much.
Good morning. I'm very happy to be here today, and I'd like to thank the National Coalition on Healthcare for hosting and Deborah Whitman for the kind introduction. As a couple of people have already said, the first version of the Physician Payment Sunshine Act was introduced in 2007 by Senator Grassley and Senator Cole. And I think if you'd called your bookie in September of 2007, or your Washington lobbyist, and said, what are the odds that this thing will become law, they would have said it was pretty unlikely at that stage. So what happened? A few things happened, and some of them have been mentioned too. We had investigations by Senator Grassley and by the Senate Aging Committee, Senator Cole. We had high-profile media coverage of the issue of conflict of interest and payments to physicians. We had state laws that required this kind of reporting at the state level and created a kind of compliance nightmare for companies that made them more willing to entertain a federal law. But we also had leadership within the medical profession that I think was also important. The Institute of Medicine issued a very influential report on conflict of interest. The Association of American Medical Colleges issued a report calling for much stronger conflict of interest standards. And we had leaders within individual schools saying we just can't keep going, our profession can't keep going the way it has. So all those things came together, and the law passed in 2010. But the other piece of context that I think isn't proximal to the law's passage, but is really important to understanding how it fits now, is this sort of much wider recognition that we really need to understand in this country the drivers of healthcare costs and where the dollars go. And if you went back to 2007, I think it would also be close to unimaginable that CMS would be publishing individual physician payment records. But that's happening now too. And so, as Rodney mentioned this morning, we now have the first report from the Sunshine Act, $3.7 billion in payments to physicians and teaching hospitals in 5 months of the first year of reporting. So that's around $9 billion a year. And those are funds that are either going to research and product development, and that's important for the public to understand, or going to drive uptake of particular products, and that's also important to understand. So where are we now? Pew has been involved in this issue in a long time, as have the other folks on the panel today and many other organizations. And since passage, we have continued to work with a working group of consumer organizations and also individual companies to build shared understanding about how the data should be presented and about some of the technical challenges in getting that data out into the public domain. Data for the first full year of reporting has now been collected, so 2014 data has been collected. It will be submitted to CMS in March, and in June we will have publication of the first full year of data, along with some delayed publication of data that for various reasons wasn't released from the first 5 months of data. So the law is moving forward. And the question is, what happens now? So let me give you 3 thoughts. One thing that I think will happen, one that I think probably will happen, and one that's important but will take some concerted effort on the part of stakeholders if it's going to happen. So what will happen is that the process of submitting data will continue and be refined, and we will have this year the first full year of data. What I think probably will happen is Center for Medicare and Medicaid Services will continue to refine the way it presents that data. And as Rodney said in his remarks this morning, the first website was not very user-friendly. It was pretty difficult to go on there and find your own physician. But CMS, to its credit, within a couple of weeks of launching that first website, put up a much more user-friendly tool to let consumers search and find their own dog. And the agency tells me that they continue to work on refining the user interface, improving the search tool, but also thinking about how to provide the data in context. By medical specialty, by geographical location, with time trends. So those are all things that they're thinking about as a way to make the data more useful. So they're working on that, and I credit them for their willing to continuously improve that. The third thing, and this is the thing that I'm not sure will happen but is really important, is the law creates a lot of descriptors for payments. So is it a consulting payment, or is it for marketing, or is it a meal? And those aren't defined in the law, and some of them are overlapping. And what we suspect right now and don't know is that probably companies are using the terms in fairly different ways. And so if the data is going to be useful and comparable across companies going forward, there will have to be a concerted effort by stakeholders outside to sort of sit down and say, well, what do we mean when we use this descriptor category? And that will have to happen. There's also, an ongoing discussion about how to provide context on this data. The law allows for individual, essentially a comment field associated with each payment. And most companies haven't used that, and what I hear from the companies is they probably won't, because from a compliance point of view, the compliance officer at a company doesn't want somebody on the front lines to be just free texting into an individual payment field, and we're talking about millions upon millions of payments here. So, so we're left with how does CMS, how does the public interpret the payments we've got? And there is some context language on the website saying what's meant by a consulting payment, what's meant by these other kinds of payments, but there needs to be an ongoing process of developing that. But there's also inevitably going to be a need for an ongoing societal process of understanding which payments are we concerned about, which ones are we okay with, and what do they mean. And so that culture change in medicine that I talked about that helped to drive the move towards more transparency will have to continue. And so the data in the public domain is really an incredibly important step and the result of a lot of hard work by the people here and people across the country in the industry. And believe me, there are a lot of committed people in companies who are spending a lot of time and money to collect this data and get it out into the public. And by the way, learning some interesting things too. I've had people from companies say, once we started collecting this, we realized we were paying the same guy from 5 different budget lines, and that was really interesting. So, but there's a lot of work yet to go in terms of collecting this data, understanding it, and then deciding as a society what to make of it. Thank you.
I'm just going to pull up my slides. So I'm Bill Jordan, the president-elect of the National Physicians Alliance. I wanted to thank the hosts for having us as well, and also the audience for being here today. I'm going to talk about the influence of pharmaceutical companies on doctors, and personally as a doctor, but also as a leader of an organization that has taken on this issue as one of our core issues around professionalism. I don't have any disclosures in terms of receiving payments. I am an employee of Montefiore and Einstein, but the opinions are my own. Just a little background on National Physicians Alliance. We were founded in 2005 to strengthen civic engagement on behalf of patients and build a community that really advocated for professionalism and really restore integrity and trust in medicine. We don't receive any funding from pharmaceuticals companies or device manufacturers. So let's talk about some of the problems of the entanglements that we as doctors have with the industry. So taking a page from 12-step, we admitted we were powerless. My name is Bill, and I am influenced by marketing. One of the key issues with physicians is that they often think that everybody around them is influenced by pharmaceutical manufacturers, but that we ourselves are immune to these influences. This was highlighted in the Institute of Medicine report, as was mentioned previously, talking about undue pursuit of financial gain or other secondary interests. The gray area is what is an undue pursuit, and many physicians would argue with the definition that was offered in this report. However, it is clear that these entanglements have an influence on clinical care, our research, and our education of up-and-coming physicians. And it really erodes public trust in healthcare. It's also clear, as everybody's mentioned, that pharmaceutical companies target physicians. Drug reps, oh, there's an error. There were 38,000 in 1995 and 100,000 in 2005. And so this is old data, but there was a drug rep for every 8 doctors. And with a cost of about $12,000 to $13,000 per doctor in the country, which is enormous. You can see on the chart on the right that detailing to doctors made up about a quarter of the promotional spending budget. This is also old data, but the percentages are roughly the same. And actually, more than half of the promotional budget was connected to free samples. So I'm going to divert and talk about that for a few slides, just because I was asked in part to talk about what are the gaps that the movement forward and transparency are not addressing. And I would say that it's mainly this budget that's going to free samples. So 94% of doctors have a relationship with pharma. That's all the red frowny faces. Doctors self-report that 83% took food or gifts. Almost the same number took free samples. As I mentioned, doctors lack insight regarding this as a general rule. And generalists, of which I count myself one, I'm actually a family doctor in the Bronx, receive 2 sales calls per day. I'm fortunate in that our clinic has banned sales reps. As was mentioned earlier, about 4 in 10 doctors don't have sales reps at their offices. And samples do have a clear effect on doctors. This was a sample case that was offered to doctors in terms of a patient who comes in who's uninsured with high blood pressure, who you tried lifestyle changes with, and then you move on to prescribing medication. And 27% said they would dispense a free sample to this patient. And about a quarter of them said they would give the free sample even though it was a different medication than what they thought would be best for the patient. And even more troubling is if this patient went on to get insurance, 17% of the doctors would continue the free sample medication after the patient was insured. There's good data as well from clinics that banning samples increases prescribing of first-line drugs, like the most appropriate drug for that patient. So I would say that overall free samples are misdirected and unsafe. It's often thought that they go to the poor, but only a third of them go to low-income recipients. And often they go to the friends of pharma reps or doctors and to their friends and families. And there's really a lack of quality safeguards that was brought forward by the AAMC report, and they're more often subject to black box warnings that come out after the drug is released to market. Obviously, it's a major marketing tool that's very expensive to healthcare. It increased patients' out-of-pocket expenses, accounts for a large portion of pharmaceuticals' promotional expenditures, and really is a main driver of the increase in spending. Out of the huge number of medications that are on the market, the ones that are most promoted are driving most of the spending. This is a report from IMS Health talking about avoidable costs in the healthcare system, data from 2012. You can see $213 billion they tallied up. You can see that major chunks of this are non-adherence, which is often due to patients not being able to afford the medications that were prescribed for them, which is directly linked to advertising. Antibiotic overprescription, which is also often linked to promotional activities, and underutilization of generics, which is also directly tied to that. So obviously there are a lot of samples, alternatives to free samples. Some of them are politically challenging, such as universal health insurance and government negotiation with prices. Things that are good enough for the Department of Defense should be good enough for Medicare. Generic options and all of the other things that are listed here, including borrowing them from academic institutions and using unbiased pharmaceutical education. I'll just flash up on the screen a few of these examples. Our founding campaign as an organization at NPA was actually called the Unbranded Doctor, which was about getting pharmaceutical influence out of the doctor's office. We went on from there to actually found the top 5 list of things that doctors should avoid because they're known to harm patients or not be helpful to patients, but doctors are still doing them. That started as a Good Stewardship Project and became the Choosing Wisely campaign. This is one example of questions that came out of that Choosing Wisely campaign in terms of asking your doctor whether you really need this medication or procedure. So definitely patient engagement is needed to engage in this issue. Obviously, a lot of the speakers have spoken about the open payment system at length, which has been getting better as time goes on. And these are just a review of the statistics that were already offered. As the data has been cleaned, the number of individual physician records has come down, but hundreds of thousands of physicians and over $3 billion. And that's just over 5 months. And also I wanted to highlight 1,300 teaching hospitals. And that speaks to the point of the formulary of particular hospitals being influenced by pharmaceutical companies. Obviously, press attention has played a big role in clarifying these issues to the public, making them more available, including ProPublica. This is one example that ProPublica offered of a doctor that was making $124,000 in speaking fees, where physicians are already paid much higher in the US than in other countries, even accounting for cost of living. And then you'll see that AMSA has been a great partner in this, doing a scorecard for teaching institutions, the schools, but also all of their academic affiliates, which don't always have the same rules as the school that they're affiliated with. There is industry-free information on drugs, including this example from Consumer Reports. There is conflict-free education. NPA has led national grand rounds that has been in part funded by an Attorney General grant, and we've worked with partners like AMSA and Community Catalyst to get information out to academic institutions around the country and practicing physicians to really change the culture and become more aware of the seriousness of this issue. So we can use transparency for good, and I'm hopeful that this will continue as the open payment system improves. It acts as a shaming tool, for better or worse. That's a speed bump for getting involved in these entanglements in the first place, and also allows for the possibility of loss of peer respect when people become aware of these relationships. Also affects patient opinion. Patients are often very concerned when they find out that the doctor that prescribed them a particular medication has received payments from the manufacturer, and can have career implications as academic institutions increasingly have strong policies around conflict of interest. And obviously we need to follow the money to know where most of the money is going and how to improve the situation. This is a quote taken from a panel around the IOM report. And I hope that this will be a springboard for action as we have better access to information on this issue. Thank you.
I think we've had a wonderful panel that have raised lots and lots of issues, and I just wanted to highlight a couple key points. One is that there were a lot of different industry players, both pharmaceutical and medical device manufacturers, that embraced the idea of transparency. Some did it because of consent agreements initially, but I think moved forward being very open to the issues around transparency. And some were real voluntary leaders. And so I really want to cite the fact that there wasn't massive industry opposition, at least at the federal level, to this legislation. As Alan said, it has changed their business practices from what we've heard, but that there really was a coming together across lots of groups saying that this information can be valuable to the public. I also wanted to point out Rodney's point on clinical research and the value of knowing when researchers have conflict of interest. Senator Grassley's office did an amazing series of investigations that highlighted some of these conflicts that weren't being reported to medical journals. And several of the medical journals have, as a consequence over the last several years, really changed their practices on disclosure. And you could hear that from the doctors as they got up today and announced whatever disclosures that they had to make. That is a lot more common, and we think that that's beyond the legislation itself, a good thing for all people to know who's funding what information. A couple other points we heard about the legislation, that there were limits on coverage. The Physician Payment Sunshine Act was targeted towards physicians, and as we heard, different states have expanded that coverage to other prescribers, to nonprofits or other that engage in conversations around the use of medicine or around healthcare decision making, and I think that that's an area for further exploration as we look for where this legislation will evolve and information that is still missing. And finally, I think the amount of work that is being done to actually pull out the insights from this data. I do also want to commend ProPublica and others who have been, really tirelessly trying to look at correlations. And then I want to finish with a question, and then I'll open it up to the floor, which is to Rodney, because I think his boss really has set the standard for transparency in a variety of different ways. And in particular, the legislation or the push to CMS to release the payments by CMS directly to doctors, along with the Physician Payment Sunshine Act transparency. My question for you, and please, I want to remind all the panel to use your mic so that people that are watching this at home can understand. How do you think that will transform what we know about the industry relationship with doctors and about prescribing patterns and other healthcare utilization issues?
We don't. But we will more, and that's the sort of the value of at almost simultaneously having CMS release Medicare payment data to providers and the Physician Payment Sunshine Act, the Open Payments website coming online within months of each other, that it does provide opportunities to look at the payments and the patterns of practice. And so it will give us information, particularly as research is done, to see what is going on there that will inform us in the policy-making realm as to what might be necessary, what might be things of interest or not. And again, consistent with, I think, the theme from Senator Grassley, is that we're better off with more information than less.
And then my next question to Alan and the doctors on the panel, if I'm sitting at home and as a consumer and I want to know what are these relationships from my own doctor, how do I go about getting that information? What's the best resource that you think is out there for consumers to understand this new disclosure database? Alan, do you want to take that one?
I think right now there is some context information on the Open Payments website that is very general descriptions of what's meant by the different payment types in there. Beyond that, I think you need to look to a variety of resources, and I think different people will make different decisions about how they interpret and value those payments. But you can look to organizations like Adrian's, like NPA, Consumer Reports, Consumers Union, as well as to industry websites and continuing medical education companies and so on. So I think right now people need to read broadly so that they can make up their own minds.
Adrienne, do you want to add to that?
Sure. Patients shouldn't see physicians who see drug reps. So it's often easy to tell whether somebody sees drug reps or not. And they should be looking up their doctors on Dollars for Docs in the new database to see what money that they're taking from pharmaceutical companies. That can be really useful. It's less useful to sort of figure out what the effect is on individual drugs. As I said before, marketing starts 7 to 10 years before a drug comes on the market. A patient isn't going to know what's in the pipeline. But they should have a conversation with their doctor. If there's payments on that website, they should be talking to their doctor about it. But I think patients shouldn't see docs who see drug reps. And by the way, I misspoke before about the 40%. 40% of physicians limit or forbid drug reps to see them. About 1 out of 4 doesn't see drug reps at all. But that still leaves plenty of doctors out there.
And Bill, a similar question. You talked a lot about samples, and I've been offered samples by my own physician. What are the questions I should ask as a consumer in the doctor's office when that is offered to me?
Say no.
I think, yes, just say no. But we know that campaign didn't work. So I think I think that all patients should ask their doctor, do I have other alternatives to what you're offering me? What are the pros and cons of this and any alternatives, including the cost? And that often leads to a better decision, both for the patient and the doctor. I think that it's great for patients to become more aware and to think twice about seeing doctors that have clear pharma reps coming into their office. It's not always possible, but I think having more of an activated patient makes a huge difference in terms of thinking about these issues.
I have to say that samples are the most effective marketing tool that pharmaceutical companies have, and it would really be worth it to see the look on the doctor's face when you hand back a sample and say, I'm sorry, can I have an older time-tested medication, please? And really, it would be the best thing for your health.
You also mentioned Consumer Reports as another place to look, who do studies of drug costs and effectiveness, and there are very great resources that they have. I'd like to open it up to the audience to ask questions. Please wait until the microphone is handed to you by Mr. Larry McNeely from NCHC, and raise your hand, and we will get your questions for this amazing panel. Right here in the front.
Hi, Joyce Frieden from MedPage Today. For Ms. Fu Berman, I was interested in what you said about how pharma companies have different marketing targets now, and that they're getting into, you know, who does the doctor's son play baseball with and all that. Is that a relatively new thing, or and can you give examples of what they're doing?
Targeting people around a physician is not new. It's called molecular targeting. So the targeted doctor is the atom, and everybody around them is the molecule. So that's not actually new. While physicians know that a drug rep who comes into the office is there to sell them something, they're not really being suspicious of their receptionist or their golf partner or their friend. So if a marketing message gets conveyed through that person, through another person who isn't a sales rep, it's much more effective. Marketing messages, by the way, are not necessarily about using a specific drug. It might be that the marketing message might be that excessive sleepiness, it's not a joke. It's a real condition. You know, low T is a tragic epidemic, or that a particular competing drug is so problematic, no one should prescribe it. So every drug, when it comes on the market, has 15 to 20 marketing messages associated with it. Many of those marketing messages have nothing to do with the drug itself. It's very, very difficult to figure it out.
Other questions from the audience? Yes.
Thank you. My name is Shay McCarthy. I'm here on behalf of the CME Coalition. Adrienne, you raised an interesting point during your discussion about marketing practices, and one thing that you mentioned is that one place that might go unchanged is the practice that you see around continuing medical education. And as you on the panel likely know, there are many firewalls in place to ensure that accredited CME providers are prevented from allowing pharmaceutical companies or other commercial supporters to have any undue influence over the content of those CME events, the speakers, or any influence on the attendees. But as you also may know, this is an issue that's kind of come under a little consternation during the rulemaking process. The Wall Street Journal recently reported that CMS has essentially changed their position or their interpretation as many as 5 times on whether CME payments should be reported. And so my question for Rodney and for the panel, Rodney, you may be able to provide some context on the congressional intent around the reporting for accredited CME payments, but especially considering the unique reporting challenges, considering that firewall is in place to make sure that the medical device manufacturers or the pharmaceutical companies don't have any influence, and they don't know, for example, who the speakers are that are being recruited for those events. How could we overcome some of these reporting challenges? Was there any conversation on the political side about whether those payments should be reported? And then are there any other thoughts on the panel about reporting for continuing medical education?
We'll start with Rodney and then Alan.
CME, continuing medical education, the conversation there is ongoing. That we spoke to CMS, we talked to folks who are from the CME side of the world throughout last summer, and CMS, as they issued their follow-on regulation as it relates to reporting there. We encouraged CMS to go slowly, be deliberate, most importantly, get the initial reporting right, have that to become more substantiated, expected, that the questions about how the reporting there worked prior to aggressively trying to get into the CME world, because the CME world is, again, much more complex because of some of the nature of the blinded transactions that occur there. And so we are open to conversation about that, and we consider this an ongoing conversation. But we right now are in the position that I think CMS is moving at an appropriate speed where CME is concerned. We know they've bounced around a bit. And it's challenging because they issue a regulation, it says one thing, then they pull it back slightly, it says another. And so the Wall Street Journal piece is one where it seems somewhat confusing to us, but I think it's because the back and forth over it has been confusing. But ultimately, this is one that's ongoing, but in the main, it's getting where we are right first before, I think, fully jumping in on CME. That's, I think, where we're standing.
And I would just add to that, I think CME has always been a tricky issue, and for folks who aren't deep in the weeds here, the doctor to maintain a practicing license has to get a certain amount of continuing medical education every year. And what's happened over the past decade and a half is more and more of that continuing medical education has been funded by the drug companies or the companies that make certain products. And the challenge is, as the questioner pointed out, the funding always passes through an intermediary, and it's technically an unrestricted grant, and there are various firewalls in place. Now, everybody who's looked at this, from the Senate investigations to the Institute of Medicine to the American Medical Colleges report, have all expressed deep concern about the potential of CME funding to influence prescribing. But it's been a technically tricky issue of how do you capture it. And so what CMS seems to have come down on, and it has bounced around, is saying if a company finds out within the year that their funds were used to, that went to a particular doc, then that's a reportable payment. And that's consistent with how other indirect payments, other payments through an intermediary, are treated in the law. So that's where it stands now.
Adrienne, did you have something you wanted to add?
Yeah, CME is the most effective covert form of marketing that pharmaceuticals companies have. Pharma doesn't fund what doesn't help pharma. And the firewalls are basically a joke. Pharma may not be telling a medical education and communication company who they should have speak or what they should have them speak on, but the company knows who to invite and who not to invite. And the concept of an unrestricted educational grant, it's only unrestricted if nobody at the event says something that pharma doesn't like. I've actually had the experience of speaking at a pharmaceutical company funded CME where the drug reps packed up their booths and left after my talk, and the pharmaceutical company withdrew its funding.
Bill?
I think it's a deeply troubling issue. I think most doctors pay dues to professional societies, and so there is the money to have conflict-free continuing medical education. So there really isn't a need to take it from drug companies. So this is very challenging, and I think there's a real issue with the transparency around this specific issue because it's not clear that disclosure helps as much in this issue. The audience often says, "Oh, it's great that they're being honest," or about their disclosures, "Oh, they're really an expert because they get money from 5 different pharmaceutical companies." Or it just ends up being brand recognition, and a kind of guerrilla advertising. So it's really challenging to make this work, and I don't think there are good solutions other than really us as a profession paying for CME and not relying on industry financing.
Yeah, and by the way, we have a list of free, pharma-free continuing medical education on the PharmDow website.
One thing I want to be clear, because I feel like we've all talked a lot about pharma as part of the Physician Payment Sunshine Act, and it also covers medical devices, where there are very strong industry ties. There are required training at sometimes by the FDA in order to use a particular medical device. Alan, can you talk a little bit about medical devices, because I don't think we've touched on that much today.
Yep, and I want to, again, just to echo something you said earlier, say that, we work closely with a number of companies, including device companies, that are just so fully committed to being transparent about these financial relationships. And I don't want to shortchange that commitment in any way. But on the question, yeah, with a device, often, a drug, you prescribe it and the patient takes a tablet. It's a fairly simple process on that level. Obviously you have to understand about the drug. But with a device, there's often hands-on training required to use it. And so there's a much more intrinsic relationship there. And medical centers who've developed conflict of interest policies have often treated those device reps somewhat differently from pharmaceutical reps because they are much more intrinsic in the process of learning how to use the device.
Other questions?
Hi, I'm Jesse Kirsch with the Medill News Service here in D.C. And I just wanted to ask you talked a lot about the powerful marketing ability of these free samples that reps give to doctors. Is there any other use for those samples to the reps? Like, are they still conducting any form of testing sometimes, using these samples as trials in any way? And secondly, the ethics of the involvement with drug reps, which has been talked a lot about this morning, is that something that is starting to be incorporated into medical school ethics classes and this secondary extra education that doctors continue to get?
Samples are purely a marketing device, and they do not serve they do not serve a good purpose. They're the most effective marketing device that docs have. Some schools have incorporated training about interactions with drug reps. I have to say that a lot of the training is really bad, especially when it's actually done with industry drug reps, that industry will sometimes actually cooperate in these programs, and medical students are then left with the impression that there are good drug reps and bad drug reps, and you should avoid the bad drug reps and only deal with the good drug reps, which is really not a good message. The message should be you should not see drug reps, and that needs to be modeled as well as taught, that if students are taught one thing but all their mentors are doing another, they will adopt what their mentors are doing.
Bill, you want to add to that?
Yeah, I wanted to echo that in terms of the very limited utility of free samples. I think that there are issues in terms of off-label use. They're not the drug reps are not supposed to come and give them for off-label use, but they're not using them for any sort of study. That's not allowed. It's for FDA-approved uses is what they're supposed to be restricted to. But I would say, right, there are some schools that are doing education around this. Where I teach, we do have a class on this in our bioethics series, and then I actually lead a session during the 4th year for all of the students during their ambulatory rotation around a patient that comes in and had been put on a bunch of samples while they were uninsured, and then what the complications of that are and how you disentangle from that.
That's great. Other questions from the audience? Yes, here.
Hi, I'm Barbara Tomar. I'm with the College of Emergency Physicians, so this is of great interest to us, and we, as has been discussed, we've been all over the map trying to work with our meeting people as policy people in DC as to what the rules of the game are. But as I'm listening to the conversation, I'm beginning to think it would have been good to have somebody else here who could sort of represent another point of view, because it seems like everybody's pretty much on the same page. But one of my questions was, and I'm not sure if it was in the section in the ACA or it was in the original reg, parsing something down to $10 to me seems absurd. And that's what happens with a lot of the things, I mean, many things in the ACA, where by the time you got down to the regs and the guidance, it's become almost absurd. So I was just wondering if you could talk a little bit about that.
The $10 limit was actually in the law itself.
Yeah, the de minimis standard, which was $10, was created legislatively and ultimately became part of the regulation and how it is. And we've seen through the early rollout that certain manufacturers, when they reported data, they went below the $10. CMS, when we spoke to them, they had a challenge and what to do with that, and they went with the decision that ultimately, if it was reported, it should be published. I think working with manufacturers down the road as to whether or not they would take, whether or not they'll accept and publish reported below $10 is something that will occur on the road. To something else that you said, I think again, and I hope we've been clear about that. I have been clear about this, representing us in my office and the work that we've done here. This is a conversation, and that anything that you hear here, I respect a position that's taken that drug reps evil, that conversation. That's between you and your doctor. Now, if you're an educated consumer, and this is where we would encourage you as a consumer, learn more. That you make complex decisions, economic decisions as to what is things that you want and do not want all the time. Think about the amount of work that you put into determining your cell phone, what phone you want, and the service you want. Do I want the I? Do I want the Samsung? That Windows thing, I don't know how that works. And then there's the whole T-Mobile, and you got your Sprint, and you got your AT&T, and who else? Where am I getting this from? Oh, and then there's the Verizon thing. You go through and you make complex decisions related to that, and you make your value judgments as an educated consumer. Well, you have a responsibility to do the same as a patient, so that when you walk in, that you will never have the advantage of information that your MD does because they went to medical school. But you can engage in an informed conversation. And so if you see information there about what your provider has taken as part of this database, you can ask questions. You can engage. And that's what we encourage. If you want to take absolutist positions as your role as a patient, that is your right. And you now have that tool. But you also have just as much a right to engage in conversation. And that's where we'll continue to push that. And if the day occurs that we have information out there that allows us to take positions of an absolutist nature and make changes because we look at the consequences and the research shows us that, that's always also out there for us as a matter of policy making.
I'll defend the $10. In fact, I think it should be $1 because what social psychology research shows us is that small gifts actually have a larger impact than large gifts. So I won't go into the experiments, but essentially when you receive a small gift, it changes your opinion more because then nobody likes to think that they've been bought off by something small, whereas if you're given something large, you're suspicious. But if you're given something small, you actually change your opinion, and you think that it's because it's just an independent change. You don't think that you're affected by the small gift. So, and I'm happy to share that research with you.
Other comments?
I think you're right that there is a burden associated with tracking and reporting the sheer number of payments, and that's a byproduct of the drive for transparency. It may well be over time, and I'm not sure which $10 gifts that your members are most concerned about, but it may be over time that companies just say, you know what, we're going to do fewer sandwiches. And it may also be over time that doctors say, you know what, we actually don't need the sandwich. So I think time will tell.
Yes.
I'm Will Schaefer, and my only disclosure is I'm the medical director for the American Academy of Orthopedic Surgery, and no other disclosures. Part of this conversation is confusing to me. You know, obviously there's industry-supported CME that is all about selling their product and selling their devices, and that's very clear. Then there are CME programs such as what we put on that are blinded, you know, in that even the papers that are picked are blinded to the surgeons who are picking those papers to be delivered. And this, I guess I'm directing this more to Rodney because we've discussed this in the past. I don't believe that the intent of the law was to discourage association, CME, and continuing medical education. You said that this is legal behavior, but yet it's very clear that we're parsing this into legal but immoral, or illegal but disdainful behavior, and I don't think that's the intent of the law.
I'll try as hard as I can and keep at it, which is immoral, disdainful. I just reject associating that with my remarks and my boss's work here. That in the case of continuing medical education, it is not. It is an ongoing conversation. It is something we think is warranting further conversation, but we're not leading the charge. Let's go there right now, particularly because of the complexity of the nature of that. I believe, you know, we talk about journal articles. That's one where the ability of a manufacturer to provide journal articles to providers out there, and whether or not that should be reported. I know that's one that you and I very personally spent time on, and that's a challenging one. Absolutely, but ultimately, I'm comfortable with sitting down with my provider and asking about a payment showing up in the database and having her tell me that, well, this is related to learning more about this condition, which you don't have, but another patient may have, and that's why that was there. And that there are choices. It's to not take it, it is to take it and report it, or to purchase it on your own. And that those are legitimate choices. Providers have the opportunity to make those, and then the reports go to the database, and consumers, the patients, can ask. And we continue to believe that's totally legitimate, legal. And attaching, we're not rushing to attach judgment here, and I hope I can continue to make that case successfully here.
Can you wait, Mike?
Oh, sorry.
The idea that a physician should never talk to a pharmaceutical rep or a device rep is like saying, please go find a cell phone, but you cannot talk to Vodafone, you can't talk to Verizon, you can't talk to AT&T. And I still believe that this country those behaviors are not illegal.
Right. And I get the point, and I realize I'm sitting next to judgment here, and I'll give her the opportunity to make her case. But we're not there, and we don't necessarily agree with some of the things. Hell, I cannot wait to go to my wife on our upcoming anniversary and tell her that I heard that, little gifts were more meaningful, so I'm just saying that this Snickers bar versus dinner at a nice restaurant, I'm just saying I heard this was the case.
You said she's watching.
I'm just saying. And so, I want to make sure there's a distinction between the remarks I'm making and where we've stood and what we've stood for in the legislation, and maybe some other things you're hearing from my colleague.
And to Rodney's wife who's watching, she can ask for a large box of
Frequency is
chocolate.
important. More flowers, more candy. Probably people in the audience don't know that when they undergo surgery, that there's often a device rep in the operating room assisting the surgeon, although they're not allowed to touch the patient. If you're afraid about relationships between drug reps and physicians, you should be way more afraid of the relationship between medical device reps and physicians, that this really contributes to using new untested devices, and people may or may not know that medical devices actually don't have to have been inserted in a human being or tested in human beings before being put on the market. We've had many disasters with metal-on-metal hips in orthopedic surgery and with many other medical devices where we've learned about their dangers after they've been in use. But this is a really complicated discussion that we don't have time to get into, but there's a lot of ethical and there's a lot of not just ethical discussions, but real patient harm that results from the relationships between medical device reps and surgeons.
Yes, in the back.
Good morning. Thank you very much to the panel, and thank you for the National Coalition on Healthcare for putting this discussion together. It's very interesting from my perspective sitting here. I'm representing rare diseases today. My name is Miriam O'Day, and I represent individuals who have alpha-1 antitrypsin deficiency. Have you ever heard of that? Oh, yeah, you could. So alpha-1 is a genetic lung disease that individuals develop even if they have not smoked. And for people with rare disorders, I will tell you that we used to quote that it took 7 years to diagnosis, but actually in October of 2013, NORD, the National Organization for Rare Disorders, did an online survey, and they're now saying that it takes at least 10 years or more. 20% of respondents said it takes 10 years or more. One of the ways that physicians learn about this disease and learn about the treatment is by CME and also through dealing with drug representatives and hearing about meeting patients who have this disease, who often go in with the drug reps to talk about physicians and talk about their disorder and how they were diagnosed. So I wonder if you could make some comments. Many of the things that have been said make a lot of sense when we talk about common disorders, but not necessarily rare diseases. And then I have a few other questions. I wanted to ask you, Dr. Berman, if you could define invented diseases and whether or not you think that that's by guidelines being revised because of pharmaceutical companies, or whether that actually you were referring to drug licensure parameters. And then how should patients be educated to understand transparency, and what should the transparency be for voluntary health agencies that actually serve patient interests?
A lot of questions there. Adrian, I'm going to let you start, particularly because you did mention issues of invented disease, and this question was about what about the people that are rare disease and that many people haven't heard of? Is this transmission of information helpful actually to consumers sometimes?
Consumers are really important in this conversation, and consumer advocacy organizations for rare diseases and other diseases are really important, but it compromises what they have to say when they're taking money from pharmaceutical companies. And there are organizations like the National Women's Health Network, the National Breast Cancer Action, and Health Research Group. There are consumer advocacy organizations that do not take money from pharmaceutical companies, but are still extremely active at getting getting health issues and topics that don't receive enough coverage covered. So even if you're a small organization, you can still get attention and get the word out without pharmaceutical money. In terms of invented diseases, this has also been called disease mongering by Lynn Pear, or selling sickness. And I use it to refer to conditions, or as industry calls them, disease states, that have literally been created by industry and put forth through third parties, because they will hire and convince key opinion leaders and advocacy organizations, et cetera, to make particular conditions accepted. So social anxiety disorder, for example, and GERD, and some of the others that we've talked about before, but these are actually invented out of whole cloth. I don't remember what the other questions were.
The one, and Marion, we've met on numerous occasions, and I get your point, and particularly, but coming back to where we've been again and again, which is, a provider who wants to become more educated is okay, and no provider should be uncomfortable talking about it. I don't remember, Dr. Schaefer, if this was you gave this as a case of you, or you brought me someone from Iowa who we talked about this, which is, in Iowa, sometimes we'll have physicians rotating between different hospitals, and so they'll have walk into different surgeries. And we discussed, okay, in one hospital they have a certain type of device for a hip replacement or a knee replacement, and so being able to come in, consult the manual, the instructions related to that you need is important to have on site. And if it is gone missing or is not there, being able to get one immediately. If that then is counted as part of that. If I come to you and say, oh, there was this report here on open payments that talked about this, that had this amount, and you can tell me that, oh yeah, that was to get the instructions on hand for the purposes of your knee replacement, I'm good with that. That's a good thing. I want to keep posing that there are potential positives here. We're not in the absolutist position here, that the opportunity to gain education here is something that is available and no one should be afraid of. And really, no one should be afraid of explaining it to their patient. If you're uncomfortable with it, then that's your concern. If you're uncomfortable as the provider having that conversation, that should be a concern. But in so much of what we talk about, and where Marion, where you went, I'd be incredibly happy to have my provider to be able to tell that if it were related to me. Yeah, this is where I got, and there's this rare disease, and I actually had this because I was talking to someone. I consider that valuable.
Alan, you had a comment?
Yeah, just a couple of thoughts. One is, if it's taking 10 years to diagnose a rare condition, then the system isn't working. That's the first thing to say. And then, I think of a rare Beckwith-Wiedemann syndrome or something that doesn't have a drug treatment. So we've got to have a system where diagnosticians are learning about rare conditions, and we're not dependent on the makers of products to teach them how to diagnose. And also, I think nobody here is saying that alpha-1 antitrypsin is a made-up condition. It's very real and a very serious condition, and has to be appropriately diagnosed and treated.
I think that it's very challenging to get everybody on board with information, right? I mean, it's a huge operation, continuing medical education, and it's a huge operation, medical education in general. And I would say that that you could say that it's a failure of the profession to reach out to advocacy organizations to learn about these health issues, like alpha-1 antitrypsin deficiency, and to really educate providers about this. I would not necessarily say that becomes a justification for getting funding from medication manufacturers or device manufacturers. I think that we want to know about these things, but we also want to empower patients to ask simple questions that can be very powerful. The same way I said, are there other treatment options? What are the pros and cons of those? Every patient should be empowered to ask their provider, are there other diagnoses that we should be thinking about? I've been suffering with these symptoms for a long time. I don't feel like I have a good handle on what's going on. Are there other things that we should be considering? So I think having an activated patient is often the key to solving a lot of these issues, and can be applicable across a lot of rare diseases, not necessarily just one specific one.
So I'd like to use the last couple minutes for the panel for a lightning round. Obviously, this is the law of the land. We've heard a lot of areas in which it can be expanded from the panel, needs to be improved from the audience. What are one or two things that you would like to see either with the Physician Payment Sunshine Act or with other ways of improving disclosure that you think will be next steps going forward? Rodney, we'll start with you.
Lightning, it's CMS's ongoing work, improvement of the website. Again, we look at it as the next 2 to 3 years for that to become accepted, respected, expected, and that it works. That to us, I think, is what is most important right now. Outside of that, then we can talk about other issues. But that's where I think where we are right now, is it working and being established.
Let's have required disclosure for all organizations, national, regional, and local, whether medical or consumer advocacy, anything related with health.
And I mentioned a few this morning that are within the scope of the current law. I think beyond the scope of the current law, it would be lovely to have other healthcare providers covered.
I definitely agree with making the website function as well as possible so that we can really easily see outliers in the profession, so that can really be used to drive culture change.
Well, join me in thanking this panel, and thank you to the National Coalition on Healthcare and John Rother for hosting this event.
You were great. You're really good.
Now we go live to the